putting her on clopidogrel.
The benefits?
Yeah, what are the benefits?
Maybe no more strokes, no more clots.
Yeah, it's an antiplatelet, so I really want to make sure that we don't have more blood clots. I did tell you that the current thing is they are starting clopidogrel while they're given TPA, but your book says 24 hours. So according to Iggy, the standard is 24 hours, okay? And then, are there any stroke-related benefits for her continuing her simvastatin?
I mean, it'll keep her blood pressure controlled and her
Simvastatin treats blood pressure?
her heart rate.
Reggie, is that true or false? What's it treat? Cholesterol.
Oh,
Simvastatin is an anti-cholesterol medicine. So if there is a benefit, because we know that plaque is one of the causes of the ischemic stroke that broke off and is now lodged in her brain somewhere. So we want to make sure that we do that and keep her on that drug. Where's my little clicker thing? What are core measures?
things you have to do for every person.
There's a protocol,
Evidence-based practice.
Okay, they're evidence-based practice. Lots and lots of studies. And so there are hundreds of core measures for all different things. It used to be, and I haven't been in the hospital in a while, but it used to be that each hospital had to choose 5 core measures, and they had to meet the standards for those 5 core measures. They don't have to meet the, it's impossible to meet the standards for 100 core measures. So each hospital got to pick their own focus. So most hospitals usually have something to do with labor and delivery. Most hospitals have something to do with an MI. They have something to do with pneumonia, a UTI, and strokes. So our core measures for a stroke. This is our core measures that are mandated. If you have a patient who's admitted with a stroke, these are the things that we expect you to do. Thromboembolism prevention. So they got to be on some sort of antiplatelet, anti-clotting drug. Okay? They're going to DC home with an antithrombolytic. So warfarin, Eliquis, Savasa, all of those drugs right there. If they have AFib, they have to have anticoagulation. They have to have thrombolytic therapy within 4 hours of the time of onset of stroke. They have to be evaluated before they go home. They're DC'd on a statin. What if my cholesterol is normal?
it's going to maintain it.
I'm still DC'd on a statin if I've had a documented stroke. They got to take it. Some of them will, some of them won't. It's part of the core measures though, because it does show that there's reduction in future strokes. They have to have some stroke education, and it has to be documented. Because I can talk to you all day long, but if I don't go back and document the teaching, did I really do it? Nope. Does it give me an opportunity to say, I taught them all about simvastatin, they understood or they didn't understand, and further teaching is necessary. It enables me to communicate with other healthcare providers as to what education still needs to be done, or what they got or what they didn't got, what needs to be reinforced, things like that. Rehab assessment. Do all stroke patients go to the rehab?
No.
No. But everyone that's admitted to the hospital has to have a rehab assessment done before they're discharged, even if they're going home, to show that they either did or didn't need rehab. If they did need it, it was offered and they went, or it was offered and the family chose to take them home. Okay? Where are they going to have the better outcome? The rehab. Unless they're going home with somebody who's a rehab nurse.
Not to go too far back, but what was the post-stroke benefit of the
It's an antiplatelet. It keeps the platelets from clumping up. Yeah.
So those core measures are specifically for ischemic. That's so there's a totally different one.
Totally different one for ischemic stroke, or for a hemorrhagic stroke.
Yeah. Okay.
Yeah, those are completely.
But these are what we need to know. We don't need to worry about the other ones.
Yeah, we're going to talk about a hemorrhagic stroke and what you can and cannot do for the patient. and you'll see what the difference is.
Okay.
Okay?
But we do need to be aware of this for
Yeah, for the ischemic stroke. Your healthcare provider writes the order for a consult for speech therapy and a barium swallow. What's the rationales for that?
Swallowing.
I'm assessing for dysphagia. I'm trying to prevent my risk of aspiration. So that's what they're doing there. We're going to talk about your speech therapist and your dietitian and what they can do and what they cannot do to help you take care of this patient. Because I don't know about y'all, but I couldn't take care of this patient by myself. I just physically couldn't do it, and I don't have the knowledge to treat every deficit they might have. So your speech language therapist plays a role in swallowing and regaining their speech and the use of if it's a muscular thing, the use of the muscles in their mouth to talk. Modified diets. This is just a quick review. We talked about these in level 2. You can go look them up in your book. I think they're in chapter 60. Modified diets. The texture, the consistency, whether it's liquid or not liquid. What does bolus size mean?
in your mouth.
How much they put in their mouth at one time. Because if they're having difficulty swallowing, I want their bites to be smaller. You know, if they're pocketing it in their cheek, I want the bites to be smaller before they put more in their mouth. Positioning and posture, is that important when they're eating?
Yes.
Yeah, if they're all slumped down in the bed and they're not going to be able to swallow as well or as easily. The chin tuck when they swallow, speech therapy can teach them that. It's a swallowing maneuver. And then they can teach them specific exercises for the tongue and the range of motion of the teeth and jaw and chewing. Y'all know about NG tubes and about feeding tubes, because I'm sure everybody's had one by now with the patient.
No.
No? You're a little free. Hey, I never did a bed bath after I graduated, so. Never did a bed bath after I graduated. I'm serious. I never had a patient who needed one. I know. I got them in the bathtub. Okay, I can feed my patient 2 ways. I can do a bolus feeding, which means I go in every 4 to 6 hours and I stand there and let it go in by gravity, or I can put it on a pump. The one disadvantage with the pump is they a lot of times get severe diarrhea because you're not used to having the GI tract going 24/7. The other thing with the gravity one, it gives them a chance to be hungry, and then you feed them. So when they can start eating and swallowing on their own, it kind of mimics mealtime. So there's advantages and disadvantages. The advantage to the continuous infusion is I hang the bag and I don't have to worry about it. You know, so they do both ways. I like the gravity feedings. I think that they're better for the patient, but I'm not a prescriber. Tube feedings, cost effective. They maintain the GI tract. They help you maintain normal blood sugar levels. So there's a benefit to doing those if your patient needs those for swallowing purposes. Thicket. I can do thin liquid, which is just regular clear liquids or whatever. I can do honey thick, or I can do spoon thick, like it's pudding. So I can do all of those with my thicket. What happens when I mix thicket with fluid? And let it sit there. It gets thicker and thicker and thicker. So I need to be aware of that, because if they can have honey thick, I want to make it honey thick. I don't want to come back later and have it be, you know, concrete thick. So, it's true. Then we have the fancy trays that they send up with the mashed food. Does it look appealing? No. They're trying to make it look appealing. The other thing is, you'll see the patients get the same peas for 5 days in a row because they mashed up a bunch. And then the next 5 days they'll get mashed up carrots. Not a lot of variety for the patients. It's just, but you know, if that's what you can eat. Do patients like complying with this? No, they really don't. They really don't, because in their mind they should still be able to eat and swallow the way they normally used to. Communication. Apraxia means you can't use the muscles. Dysarthria is the same thing. Aphasia. have some sort of brain injury that affected the speech center, and cognitive deficits. Something's not there. I mean, I can talk to you, but it makes zero sense at all. So you have different kinds of barriers to communication. Our types of aphasia, Broca's and Wernicke's and global. What's the difference between them?
Broca's where you speak, but it doesn't make sense.
No, it comes out, is the one.
Wernicke's is you can.
You got to tell me which one's which.
Wernicke's is whenever you can't understand what people are saying to you. And then Broca's is whenever they can't understand what.
I lost my links. I want to show you. I want to show you a video.
Like Broca's is word garble,
Okay.
and Wernicke's is
Okay. So, Broca's is word garble. Is that true or false?
I don't know.
Yeah, expressive. Like,
Broca's is expressive. Let me find this video. It helps if you can type. Let me find the one I want you to see. It's really sad. I'm sorry, it's the best one.
School is it
Oh, hold on. This is not the right one.
boy?
Hold on. I'll
Is
show
it
you the guy.
raining down?
I want to show you the guy. It's sadder.
Isn't that sad?
This one right here is the one I want you to see.
Tell me what this thing was with your legs last week or a week before.
No good. Ache and knees and ankles.
What'd you do about it?
Home, doctor, and legs.
Okay, can you get how sad it is?
So they understand that they're not able.
Yeah, they understand what you're saying, and they also understand what they're trying to tell you, but they can't get it out. It's expressive aphasia, and it's also called telegraphic speech because it's just little bits. They get you little bits and pieces.
But it doesn't affect your writing or typing?
Very frustrating.
It can be mildly impaired, but they can't write. But they can read, but they can't write.
They can't write either?
No. Now watch this dude. This is oh, he's hilarious. I love the guy. Okay, this is Wernicke's.
Hi Byron, how are you? I'm happy. Are you pretty? You look good. What are you doing today? We stayed with the water over here at the moment, talked with the people over them over there. They're diving for them at the moment.
oh,
They'll save in the moment. He'll have water very soon for him. With luck for him. So we're on a cruise and we're about to... We will see water right here and they'll save their hands right there for them. And what were we just doing with the iPad? Right at the moment they don't show a darn thing. With the iPad that we were doing. We, like, here? I might change for me and change hands for me. It would happen. I would talk with Donna sometimes. We're all with them. Other people are working with them. I'm very happy with them. This girl was really good. And happy. And I play golf.
I don't know if he's a player.
We play out with hands. We save a lot of hands on home cookies for us. Other hands. But what you get, but I talk with a lot of hands.
Yeah.
Sometimes. Am I talking any more to say?
All right, thank you very much.
Thank you very much. I
Okay.
appreciate it. And I hope the world loves you.
Thank you.
So can you see the difference there and how sad it is? They're both sad. How frustrating it is that the one wants to tell you stuff. This dude that's making up all that whole conversation, he don't even know. He just thinks we're having a normal conversation. That's frustrating for you.
Is he able to write? Is he able to write? Understand what
I said he's living his best life.
Yeah, I mean, so when you're attempting to reorient Byron there, how frustrating do you think that is?
Well, my question is like, throughout that whole thing, he couldn't answer, but then when she said thank you, he said thank you. He said thank you. Never mind.
Yeah.
I thought you said you're welcome.
He kind of repeated and yeah. So, I mean, frustrating for the client and for the nurse. So can you see how your speech therapist can help with some of that? You know, can't fix it, but you can help with it. Global aphasia is the most tragic. They don't really understand. They don't really communicate. They're just lost. Yes, Matt?
You just answered it.
Oh, yeah. It's a combination of the two, and they're just lost. So, but can you see the difference? Yeah. Frustrating.
Say global, they're just lost?
Yeah. They lost everything. They can't comprehend, and they can't respond. That's a good word. Yeah. I was going to say communicate, but yeah, they can't communicate. They can't appropriately respond. So let's talk about these surgical treatments that we can do if our patient has this clot in their brain. A mechanical thrombectomy, a carotid angioplasty, and a carotid endarterectomy. I am going to tell you this. Carotid endarterectomy is not in your book. It might be on your test. Okay? Because we do them on the Mississippi Gulf Coast and in the United States. I don't know why it's not included in your textbook. But I have a slide and I have some notes at the bottom of the slide. So a thrombectomy, they go in and they take the little rotor-rooter and they rotor-root out whatever's there and pull it out. So if they're doing this through a groin access or a radial access, what kind of things do I need to think about when I get my patient back to the floor? Okay, I need to have them be still. They need to lay flat for so long if it's the groin. I want them to make sure I want to make sure they're not bleeding. What else? What did you say? No hemorrhaging, bleeding. What else with bleeding? What else goes with bleeding?
Their clot, their effusion.
What did you say? Sometimes they'll put a sandbag on it. Let me ask you a question. Plopping a sandbag on top of their groin, is that as effective as saying, I'm going to stand right here and put my whole body weight on that because you're bleeding? Is it painful?
Yes.
Yeah, they're going to tell you to stop. You can't stop. You're still going to stand there with the heel of your hand on there and just keep pressing on it till the bleeding stops if they're bleeding. I'm sorry for knocking you. That's fine.
So this goes into an artery.
This goes through an artery up into there and removes the plaque or the clot. Circulation. If you go in through my femoral artery, yes, you better be checking my pulses because I told you in level 2 if I lose my leg I'm going to be real pissed at you when I wake up. So you better be checking my pulses and you better be checking them bilaterally because I might have cold feet. You never know. But check my pulses to make sure. If it's a radial and I have my little band on there that they put on to control the bleeding, what better you be checking? Cap refill, are my fingers warm? Asking me if my fingers are tingly, things like that. So you're checking circulation. This is the least invasive, okay? The second one is going in there with the same thing and putting a stent. Just like you do a cardiac stent, they can put a stent in the cerebral vessels and open them back up. That's cerebral angioplasty, okay? Here is the most invasive, and it's a carotid endarterectomy. let me show you this picture first. They actually go in and make the incision. Then they go in and open the blood vessel, remove the clot that's there. They do this for people who have 90% occlusion.
My grandpa has that done.
They close up your blood vessel, then they close up your neck. What kind of things do you think I need to think about if I'm taking care of this dude? For airway,
neck.
because if I have a hematoma, I can push on my trachea and block my airway. What else what did you say over here? Okay, airway infection. I need to worry about infection. Perfusion. I need to make sure that we've altered this somehow. Am I still perfusing my brain? Coughing. Do I want them coughing? No. Do I want them deep breathing? They just had surgery.
Yes.
Yes, they can deep breathe. We can move around some, but I don't want them forcefully coughing or sneezing to put pressure on this anastomosis. I'm not really particularly worried about the one on the outside of their skin. I'm worried about this one right here on the blood vessel itself. They usually spend one night in the ICU, and a lot of times they're discharged from the ICU. Do you think I want to check their blood pressure? Yeah, I want to be checking their blood pressure because I don't want it to be too high or too low. If it's too low, I'm not perfusing my brain. If it's too high, I'm putting unnecessary pressure on the anastomosis right there where they stitch them back together. Let me look at my list of things if it's not here. What if my patient has a JP drain?
When do they have a JP?
Check
What if they have a
drainage.
JP drain?
Make sure it's draining freely.
Make sure it's below.
Make sure it is draining.
Okay, I need to make sure that it is charged or compressed or whatever word they want to use. I want to make sure that it's below the level so that it's draining by gravity. I want to make sure that I have it secured so that when the patient stands up, it's not yanking right here on their neck. What other kind of things? What if that tubing gets clotted? What if it gets a blood clot in it? Milk it. Yeah, you need to strip that line and make sure that you don't get a big blood clot in that line. Because if I'm not draining the blood and the serosanguinous fluid from the wound, where's it collecting?
In the neck.
Right here, pressing on my trachea. Midline, when I'm in the bed, I want to make sure my patient's midline so that they're draining good. Respiratory distress is another thing. What might I want to have at the bedside? Suction.
Ambu bag.
An ambu bag. Well, if I have a hematoma and I'm compressing my trachea, is my ambu bag going to do me any good?
No, just make sure you have trach stuff.
Trach stuff at the bedside. That's what they want you to have. Trach stuff at the bedside. Blood pressure every hour. And I want to make sure that it's not too high or too low. I want to monitor for confusion, dizziness, any changes in their LOC. Now, can this patient have changes in their LOC because of anesthesia? Yes. So I kind of have to monitor that. Are they getting better since I got them from the recovery room? Are they getting worse? Is this a change? Were they goofy before they came in? You know, I kind of need to know something about my patient. But I'm going to be monitoring them very closely in the ICU. Okay, so for our hemorrhagic stroke, this is the poor guy. I feel bad for this guy. There is no effective targeted treatment for a hemorrhagic stroke. So I'm just going to tell you, your whole ASLS class, that's all they're going to tell you about a hemorrhagic stroke because they're there to treat an ischemic stroke. Hemorrhagic stroke, you're going to treat your symptoms, you're going to try to prevent complications, and you're going to try to minimize deficits for your patient. That's the only thing you can do. So medical management and surgical management for them. Here is a picture of the arterial flow in the brain. You don't have to memorize this picture. I do want you to know that this right middle and left middle cerebral artery are where most of these hemorrhagic strokes occur. And that is why when they're looking at the CAT scan, if it's an ischemic stroke, but it affects a third of the brain tissue in that area, they're not going to give you TPA because if you bleed, you're going to die. So those are your biggest arteries there. They go into all this stuff and they teach you about left side and your right side. And I have a slide here. they'll enhance that. Don't get lost on that, okay? This is your AV malformation. See how this is normal. This is the way it is here. Your blood's all mixed together. What happens right in here? When the blood gets all jumbled and they get a big clot, and they usually get an aneurysm. And people are born with this, and they don't really know they have it until they have a CT scan for some reason, or they have some sort of neuro problem, and they do a CT scan. So that's your AV malformation. I'm going to show you the seizures to take care of it in a minute. Here's your treatment of a hemorrhagic stroke. Basic life support. I'm going to keep you alive. If you're on anticoagulants, I'm going to reverse them. So if you're on warfarin, what is the
Vitamin K.
vitamin K? If you're on heparin for some reason, protamine sulfate. If you're on Eliquis, you're screwed. You're screwed. There's no reversal. So they're going to monitor you. They can give you fresh frozen plasma. That will help with the bleeding, but they can't reverse the drug. Okay? They're going to control your seizures, because if you have a seizure and you have all of that going on in your intracranial space and you already have a bleed, what does the seizure do to intracranial pressure? Increases. What's going to do with your bleed? It's going to make your bleed worse. They're going to control your blood pressure, because the higher your blood pressure, the more bleeding you're going to have. And they're going to control your intracranial pressure. They're going to treat the problems, but there's nothing targeted to say you're going to have a better outcome. Hemodynamic and neuromonitoring. So that means I'm going to check your vital signs. I'm going to check your neuro status, make sure you're not getting work. I want the patient on bed rest until the cause is identified. Okay? Because if you get up and you fall and you whack your head on the sink, am I helping my problem? No. Bed rest. So, bed rest for this person. Temperature control. Because if the stroke is happening anywhere near the hypothalamus, they're not going to be able to control their own body temperature, and they're going to take on the temperature of the environment. So I want to be monitoring their temperature. Fluid and electrolytes and acid-base balances. If I don't correct those, I'm just making my problem worse. So I'm just looking for any kind of things that are wrong and treating symptoms. Hyperglycemia. If my patient has high blood sugar, and I know you don't know very much about diabetes DKA, because we don't cover that till level 4 really. But the higher their blood sugar is, the more the metabolic demands of the body are. So we want to make sure that their blood pressure or blood sugar is in the normal range. So we're just treating symptoms. I want to make sure they're hydrated. I want to manage their hypertension with IV medications. Okay? H2 blockers. Why do I care about that? Why is everybody in the hospital on an H2 blocker? Protonics. Decrease the risk of a stress ulcer. Do you think having a hemorrhagic stroke is a stressful event? It is a stressful event. Whether you recognize that or not, cognitively, it's stressful on your body. Cautious use of sedatives. Why do I care about that? Because this patient's all over the bed, and I'm trying to keep him safe.
Well, then you can't tell if something changes.
Right. I can't tell if something changes, so I really don't want to use a lot of sedatives until I get to the bottom of what's going on and make sure that I have a stable neuro patient. Okay, that's the reason why. Prevent. Ischemic strokes do not have vasospasms. Hemorrhagic strokes do. So they use calcium channel blockers to treat those. Hydrocephalus, we talked about that with our head injuries. I can have some production of cerebral spinal fluid that's more than I need, so I want to correct that. How am I going to do that in this patient? Most likely drain it off with a ventriculostomy. Here's my surgicals. I can take out the hematoma. I can do some clipping of the vessels. I can do coil embolization, and these are my 4 surgeries. I'm going to show you pictures. Well, first of all, I'm going to show you this. Reminder. Wherever this is happening is where my symptoms are going to be. So you need to know this slide. And you need to know the areas of your brain and what they do, because wherever my bleed is where my deficit's going to be. Okay? So I included that. I also included this slide right here, because if my stroke occurs on the left side of my brain, other than my eyes and part of my face, all of my deficits are going to be on the right side. So it crosses right there. And you can see where you're... These people over here, let me tell you about these people. If you had a left stroke and you have the right brain injury, these are the people that you say, I don't want you to get up without my help. Here's your call light. Here's your water. Here's your TV controller. Make sure you call me for help. I'm going to put your side rails up. And you turn to walk out the door, and before you're 3 steps from them, they're climbing over the side rails of the bed. They're super quick and impulsive. They think they can do everything they want to do. They get up from the wheelchair. So you really have to monitor them and make sure that for safety. This person over here who had the left brain injury, what? You want me to walk down the hall? They're very cautious. They don't want to do anything because they might hurt themselves. So you don't have to worry about them safety-wise as much, but they need a lot of encouragement to get them out of bed and get them moving, because they really don't want to, they're going to hurt themselves. They're super cautious. That's the difference between the two of them. They all have other deficits, but you're going to see those ones over on this side, you can't control them. You must work in a nursing home. Do you? Hospital? You can't control them. Here's our ABCs of preventing a second stroke. The aspirin or the Plavix. Here's our anticoagulants that they give them. The B is blood pressure control. The goal is 130/80. That's modifiable. We can fix that. Take your damn pills. Okay? Cholesterol-lowering medications. I don't have high cholesterol. No, you don't. But this statin drug is going to keep your cholesterol in check and lower your risk for another stroke. Okay? Smoking. Buy the patch. Take the Boost Par. Do the Chantix. Whatever you have to do. Okay? Smoking is one of the #1 causes of strokes and heart attacks. Diet. The Mediterranean diet. What do you know about that diet?
Like olive oil. Yeah.
It's fresh fruits and vegetables, grains, a little less meat, all the good fats and nuts and things like that. That's the diet they recommend for these people. And you better tell me something about the DASH diet, because you know who's going to want to know.
Low sodium.
Low sodium. The low sodium diet that they put the cardiac patients on. High protein. And then exercise, 30 minutes a day. I just had a stroke, man. Can I still work up to that?
Yes.
Like, I might the first week only be able to walk from my front door to the mailbox to get the mail and back. But the next week I might be able to actually walk to the end of the street and back to my front door. So that needs to be encouraged. Is that always easy? No. You can't take a person who's led a sedentary lifestyle and has some sort of catastrophic health event and say, we're going out today, you're going to walk 30 minutes. Because you might be back in the ER having another catastrophic event. But you can build up slowly, and they can be encouraged. So that's where rehab is just a wonderful tool to get them up moving, to get them doing things for themselves. Because just like any of our cognitive patients, how much of their care do I want to do? I want to do what they need me to do to get through their ADLs, but I want to encourage them to do as much as they can. How frustrating do you think it's going to be for that person to button their own shirt? Very frustrating. Y'all should go spend a day on a stroke rehab. It's extremely frustrating. When they see themselves eat for the first time and there's food everywhere and they're embarrassed because they know. I was just home in Pennsylvania over the break, and I have an uncle. He's 89 years old. He's the last person living in that generation. He had a stroke 2 years ago, and he basically has made himself homebound because he can't speak. He has Broca's aphasia. He can say things like, "I'm glad you came. It was good to see you. How are you doing? I'm doing well." He can answer real simple questions that are kind of rehearsed that he's learned. He refuses to eat in front of anybody except my aunt because he's messy. It's sad. It's really sad. He gets around in a motorized wheelchair. So, and she takes care of him at home, but he's 89 and she's 69. She's like 10, 20 years younger. He brought the cradle. But it's really frustrating, you know. But I mean, I saw it just firsthand. So it takes a lot of encouragement. She wants to have a 90th birthday party. Do you think that he wants to do that?
No.
He does not. Crowds make him anxious. He does not want to do it, but she does, so it'll probably happen. Just so I know my aunt. So, this is what we're going to do for the last few minutes. I'm going to give you, well, I'm not going to give you them. We're just going to talk about it. We're going to look at these things, and we're going to talk about some nursing diagnosis. I don't know what I did with my envelope. Wonderful nursing diagnosis. Okay. I'm going to read the nursing diagnosis to you. You're going to tell me which ones of our patients it would apply to. All the ones we've talked about. I know it's been forever since we talked last week. We're going to think of a goal, and then we're going to talk about our interventions. Okay, so let's just look at these broad categories. Do you think that we have clients that would be risk for aspiration?
Yes.
Okay. What about altered nutrition and hydration?
Yes.
A lot of them. Impaired verbal communication. Let's see. Falls. Mobility.
Yes.
Skin integrity.
Yes.
Okay. What do you think disuse syndrome means?
You don't use it.
Yes.
Right. I had let's say I had a left-sided stroke, and my right side's non-usable. What's going to happen to the muscles in my arm?
They're going to deteriorate.
They're going to get atrophy, and then I'm not going to be able to use them again. So that's where rehab comes into play and really helps them learn to use their muscles over. Alterations in bowel and bladder. Now our stroke patients have that. Who else might have that?
Head injury.
A brain injury. What about a multiple sclerosis patient?
Yes.
What about a spinal cord patient? So you have those patients that have those. Let's see, self-care deficit. I can't take care of myself. You know, it's not a knowledge thing. I know I need a bath. I just can't do it. We talked about unilateral neglect. But let's talk about this one for a minute. Caregiver role strain. How stressful do you think it is?
Incredibly.
Very.
Incredibly. It's incredibly stressful. It's stressful financially because what if this person who had the stroke was the sole provider? Mm-hmm. Or it took 2 incomes to make your household run and now they had a stroke and they're in rehab. Stressful?
Yep.
Yep. I weigh 110 pounds and my husband who weighs 250 pounds had the stroke. Do you think it's physically stressful?
Yes.
Do you think it's mentally stressful? And emotionally, how frustrating it would be. If you had to talk to the little man with the leg problem, and you were trying to figure out anything or get anywhere, how frustrated would you be?
Really?
Or, if you really wanted to find something out from Byron, and Byron just talked to you jibber-jabber like that, how frustrating that would be. Or he's trying to tell you something that he knows what he's telling you, and you have no idea because it doesn't make any sense at all. Frustrating. So caregiver role strain is a big thing. Some of the hospitals on the coast actually do respite care where you can make an appointment and you can bring your family member for a week and they're taken care of by the nursing staff there. You have to supply everything. Medicines, diapers if they need them, clothes, whatever. But the nursing staff and the aides at the hospital, for some fee of money, will take care of your family member so you can have 3 days of a break or whatever you need. So it's super important to identify with the caregiver. Y'all, families can be terrible and families can be great. You know, we had a patient at Merit Health one time. His name was Mr. Dickey. He's died, so I can tell you his name. He actually was an African American. He owned the first funeral home owned by African American here on the Gulf Coast. I didn't know anything about him except he was sick. He had a trach, he'd had a stroke, but his wife was my biggest helper. Like, she would suction him, she would help me turn him, she would clean him up, she would give him a bath. She was a big helper. The other nurses didn't like her because she was always interfering. I'm like, if all I have to do is get her a chair bed and a Coke every night and she does 50% of my work,
We're good.
I'm good. She's taking him back home. So she needs to know how to do it. So they can be your biggest helper or they can be your biggest adversary in the hospital. I'll tell you one thing. I have a lot of pet peeves in the hospital, but I'll tell you one of them. I'll tell you a couple of them. A full bedside commode, that's a big pet peeve of mine. And the suction canister that's been discontinued for 3 days, it's still up there, that's lazy. But my one big pet peeve is when I go in to take care of my patient and the family member is sitting there in a straight back chair and you say, do you plan on spending the night tonight? Yeah, I've been here for the last 3 nights. Really? And you still are sleeping on a straight back chair? I mean, because no one thought to take care of the family member. Make them your friends. They're like nurses' aides. The nicer you are to them, the better they're going to help you. So use your family, because they are taking the patient home, and imagine taking him home if you've never taken care of him before. It would be terrible. So we won't even talk about these because I know you're all ready to go. Here's some other ones. But when you're studying, I want you to think about these nursing diagnoses and how they can apply to these individual patients. I have one here. Okay, let me ask you this one. This guy has a risk for fluid volume deficit related to failure of regulatory mechanisms as evidenced by excessive urine output. Who would that be? Which patient would that be?
That'd be your DI.
Okay, my diabetes insipidus. Somebody with a pituitary tumor is going to have that kind of problem. So you can figure out what your goals are from your notes and stuff. Caregiver role strain, imbalanced nutrition, as evidenced by his inability to swallow and persistent weight loss. What kind of things can I do about that?
Speech consult.
Okay, she said soft foods. Okay, I could use soft foods, but what if my problem is a swallowing problem? I need to make sure that I don't have a swallowing problem before I alter my foods. So I'm going to check that out first. Impaired skin integrity. Which of our patients could have that? Almost any of them. Almost any of those patients. So skin breakdown. I need to assess it. I need to turn them if they need turned. I need to make sure they're clean and dry. Because where's your skin breakdown happen? Laying on peed pads underneath them. It's gross. Impaired physical mobility. Who can have that? All of them. Spinal cord injury. Head injury. Multiple sclerosis. What about my patient who has Meniere's disease? Could they have mobility problems? Mm-hmm. Yeah, because every time they move, they're dizzy. Disuse syndrome. Who could have that? Okay, my elderly, my stroke, spinal cord. What about a multiple sclerosis patient? Could they develop that?
Yeah.
Yeah. We talked about the self-care. Oh, let's see what this one is. Unilateral neglect. We talked about that. In your book, there's like one section about unilateral neglect that talks about approaching them from the unaffected side and how to position their stuff. Just look over that so you know how to take care of someone who has it. What about a self-care deficit related to cognitive impairments because the patient has the inability to manipulate their clothing to go to the bathroom? What can I do about that?
Just pull them down. Sweatpants.
Yeah. Sweatpants. Get rid of the zippers. Get rid of the buttons. Use sweatpants. Something that they can maneuver. Velcro instead of, if they can't do their buttons, I'm going to use Velcro. So I can alter their clothing to fix that kind of stuff. Some of these are just different things that they can have. Aspiration, we talked about that. Okay, impaired urinary elimination. And we know that because they have retention. What am I going to do about retention?
In and out calf.
Hey, I can bladder train. I can get orders to in and out calf and teach my patient how to in and out calf. What'd you say?
I don't know. Karen.
Well,
Every time you do it on the
if I have bladder retention and I give Lasix, my patient's peeing, then am I fixing the retention problem?
Oh no. You give it some.
Well, they don't usually have urinary retention. They're just not making urine. They're just not making urine. Disuse syndrome we talked about. If you don't use it, you lose it. And you know, lateral neglect. I think that's it. Okay. Study hard. Have fun at ASL.